Hello students, today's class is on hemophilia. The last class we had learned about coagulation pathway, the various coagulation factors. Hemophilia is the most common congenital coagulation factor deficiency. There are two types of hemophilia, hemophilia A and hemophilia B. Hemophilia A occurs due to the deficiency of factor 8. Now factor 8, the half-life of factor 8 is 12 hours. Factor 8 is protected from proteolysis in the circulation by binding to von Willebrand factor. So there is a close association between factor 8 and von Willebrand factor, and von Willebrand factor is important to prevent proteolysis of factor 8 in circulation. So a deficiency of von Willebrand factor can also result in coagulation abnormalities. Now coming to the genetics of factor 8 deficiency or hemophilia A, the factor 8 gene is located on the X chromosome. So hemophilia is a X-linked disorder with occurring due to a mutation in the factor 8 gene. So because it's an X-linked disorder, if a female patient, a female having hemophilia, all her daughters will be obligate carriers, and a female carrier, in the case of a female carrier, there is a 1 in 4 chance of each pregnancy resulting in the birth of an affected male baby, a normal male baby, a carrier female, or a normal female. So there is 25% chance of the progeny being an affected male, a normal male, a carrier female, or a normal female. So because it's an X-linked disorder, for a female to be affected, both the X chromosomes have to be affected. But for a male, because it's XY, a single X, because there's only a single X, even if it is heterozygous, the male will be affected. Antenatal diagnosis of hemophilia is possible by chorionic villus sampling and is possible in families with a known mutation. So if you know that a hemophilia runs in families, you can screen antenatally for this mutation and proceed accordingly. Now, what are the clinical features? The clinical features is essentially due to the deficiency of the factor 8 resulting in bleeding tendencies. So the extent and pattern of bleeding due to hemophilia depends on the residual factor 8 levels. So the level of factor 8 which is present in each individual varies and resulting in mild, moderate or severe clinical presentations. So if there is more than 0.05 to 0.4 units per ml of factor 8, it results in a mild hemophilia, moderate being 0.01 to 0.05, and when it is less than 0.01 units per ml, it is called severe hemophilia. The clinical presentation depends on the factor 8 level that is present in the patient. So mild with major injuries, in mild hemophilia, only major injuries or a major surgery will result in excess bleeding. They won't have any spontaneous bleeding. But a moderate hemophilia can have bleeding with mild trauma or surgery causes bleeding. And in severe hemophilia, there are spontaneous bleeds, especially spontaneous bleeds into joints and muscles. So joints and muscles, musculoskeletal system is the most affected system in a patient with severe hemophilia. So they will have spontaneous hemarthrosis, recurrent hemarthrosis, muscle hematomas which can get infected forming abscesses, so causing long-term debility in such patients. So mild and moderate, in mild only major trauma causes bleeding, moderate there will be mild trauma can even cause bleeding, but in severe even without trauma they can develop spontaneous bleeds into joints and muscles. So severe hemophilia, spontaneous bleeds can occur into the skin, muscle and joints. There can be retroperitoneal and intracranial bleeds. And babies born with the factor 8 deficiency are at increased risk of intracranial hemorrhage as compared to normal babies. A majority of the recurrent bleeds are into the musculoskeletal system, as we had already discussed. So it typically occurs into large joints, especially knee, elbow, ankles, and hip. So recurrent bleeding into these joints will lead to synovial hypertrophy, destruction of the cartilage, something what you call as chronic hemophilic arthropathy. So recurrent bleeding with resolution resulting in synovial hypertrophy and destruction of the cartilage, resulting in chronic hemophilic arthropathy. Muscle hematomas commonly occur in the calf and psoas muscles, and this can cause compartment syndrome, ischemia, necrosis, and fibrosis. So these muscle hematomas can result in compartment syndrome. Compartment syndrome can compromise the blood supply to these muscles, which results in ischemia, necrosis, and fibrosis of muscles. So this can result in deformities, debility for the patient in the long run. So here this picture gives the clinical features and the complications of hemophilia. Now the descendants of Queen Victoria had this factor VIII deficiency and hemophilia, and the descendants, you can see the Mendelian inheritance in this X-linked inheritance of hemophilia B shown in the figure, showing carrier states and affected individuals in the pedigree chart. The second picture shows a massive retroperitoneal hemorrhage. That X-ray shows there is synovial hypertrophy, and you can see that there is no space between the bones. So the cartilage is absent, and this is called hemophilic arthropathy. The chronic hemophilic arthropathy with joint swelling and muscle wasting. The recurrent hematomas and hemarthrosis result in deformities. So the picture above shows the left thigh muscle hematoma, and because these patients will require recurrent transfusions or infusions, they are prone for bloodborne infections like hepatitis C. So the picture shows a hepatoma in a cirrhotic liver secondary to HCV infection. So they are at risk for HIV, HBsAg, and HCV because of recurrent transfusions. A massive bruising that can happen in, so spontaneous bleeds can occur in severe hemophilia. Now coming to treatment of hemophilia, the ideal situation would be to maintain a factor VIII level by supplementing prophylactic factor VIII replacements regularly, so that the patient will have a normal factor VIII. But the course factor VIII is not cost effective in less affluent countries or developing countries, but in affluent countries they can go for prophylactic coagulation factor replacement. But in less affluent countries like in India, in severe hemophilia A, what is done is when they develop bleeding episodes, those episodes are treated by raising the factor VIII level by giving intravenous infusion of factor VIII concentrate. So in our country, what is done is when these patients bleed, as soon as they develop, the patient will report, and we give factor VIII concentrate infusions intravenously to raise the factor VIII level so that the bleeding can be arrested. These factor VIII concentrates are freeze dried and are stable at 4 degrees Celsius, so can therefore be stored in domestic refrigerators as well, so that the patient himself can start treating early if bleeding occurs. Now, the other measures are also important along with supplementing factor VIII deficiency when there is a major bleed. The other measures are resting of the bleeding site, especially if joints and muscles, with either bed rest or a splint to reduce the hemorrhage. You give analgesics for pain relief because hematomas or hemarthrosis are severe, can cause severe pain because of the collection of the blood in these restricted spaces. So once bleeding has settled, you have to mobilize the patient and by physiotherapy to restore the strength of the surrounding muscles. Otherwise, this can result in muscle wasting and result in deformities and restricted mobility of the patient, leading to chronic hemophilic arthropathies. So once the bleeding has settled, you have to go in for physiotherapy to strengthen the muscles around the joint. Another modality of treatment is a vasopressor receptor agonist, desmopressin. Now desmopressin raises the von Willebrand factor and factor VIII levels 3 to 4 fold. So, which is useful in arresting bleeding in patients with mild or moderate hemophilia A. So, it is not of much use in severe hemophilia A, where you have to go for a factor VIII concentrate. But in mild and moderate hemophilia, vasopressin receptor agonist desmopressin can be given because it raises the von Willebrand factor and factor VIII levels by 3 to 4 folds, thus arresting the bleeding. Now, complications due to bleeding can occur in patients with hemophilia. Also, there are complications due to coagulation factor therapy. One dreaded complication is an anti-factor VIII antibodies. When you are supplementing this factor VIII from outside intravenously, recurrent infusions of activated clotting factors recurrent infusions can result in the formation of antibodies against this factor VIII. Thus, the factor VIII that you give becomes ineffective. Now, in such patients, what can be done is infusion of activated clotting factors, example of factor 7A or factor VIII inhibitor bypass activity, something called FEIBA, factor VIII inhibitor bypass activity, and which can stop bleeding. So, in patients who develop anti-factor VIII deficiencies. And as we had earlier discussed, they are at increased risk of blood-borne viral transmission like HIV, HBV, and HCV. Also for prion diseases like Creutzfeldt-Jakob disease. So that's about hemophilia A. Hemophilia B is also called Christmas disease. It has a similar clinical features as hemophilia A. It is occurring because of the deficiency of factor 9. So factor 8 deficiency results in hemophilia A, and factor 9 deficiency results in hemophilia B, called as Christmas disease. It is less common. It is also an X-linked disease having the same X-linked inheritance as in hemophilia A, and the treatment is factor 9 concentrate. And in hemophilia A, you give factor 8 concentrate. Here you give factor 9 concentrate. But unlike hemophilia A, where desmopressin is effective because it increases the von Willebrand factor levels, it is not effective in hemophilia B. So to summarize, hemophilia is a coagulation factor deficiency. It's a congenital deficiency of coagulation factor 8 resulting in hemophilia A, and deficiency of factor 9 resulting in hemophilia B. The severity can be mild, moderate, or severe depending upon the residual factor VIII activity. Severe hemophilia can result in major bleeds, spontaneous bleeds, especially into the musculoskeletal system. Recurrent hemarthrosis can result in chronic hemophilic arthropathy and deformities. Treatment is factor VIII concentrate when there is bleeding, analgesics, then immobilization of the joints to arrest bleeding, and once the bleeding has been arrested, you can go for physiotherapy. You give analgesics, antibiotics in case of abscess formation in muscle hematomas, and you have to go for rehabilitation for the patient. Thank you.